Good evening and welcome to all of you, my dear friends. So, I hope that everyone is staying happy, healthy, and you have been revising medicine, whatever the topics we have discussed. So, guys, I welcome to all of you in the class of medicine. So, today we are going to discuss about the clinical case scenarios, and my target audience are obviously going to be the foreign medical graduates, people who are preparing for NEET PG examination as well as INI CET examination. So guys, before we proceed to the class, I request all of you to please show your presence by waving your hands or giving a thumbs up so that we can start today's session. Hanji, I'm waiting for your replies, guys. Thank you, Black and White. Thank you, Navpreet Singh. So, can I start? So again, today we are going to do, what we call it as, there will be 4 options as usual in your MCQ. So you will have 1 minute time to read and analyze the question. I request and I advise all of you to read the last line first and the option so that you can have a, quick idea that where the question is going to and what the answer is likely to be. That is the correct method of reading or solving an MCQ. Hello, Tarun. Hello, Sri Lakshmi. Good evening to all of you. Ji, so let's start. Okay. So here is the first question. Read this question and then we will proceed. So you have 1 minute time for this question and your time starts now. Okay, is the sound okay now? Guys, is the sound okay? Okay, let's read the question now. What is the likely cause? So options we have is Ostium premium, Ostium secundum, patent ductus arteriosus, ventral septal, defect, right? Okay. Now let's read the question. And there is a 25-year man visits you with complaints of palpitation from last 2 weeks. So palpitation, one clue. He reports that each episode of palpitation is for a few seconds, means it is a short-lived palpitation and it resolves by its own. His ECG is suggestive of right axis deviation and right bundle branch block with a prolonged TR interval. What is the likely cause? Ostium premium, secundum, patent ductus arteriosus, or VSD? So guys, first of all, we have to understand that what this patient is having. So basically, guys, this patient is having, this patient is having atrial septal defect, first of all. Now, when we talk about the atrial septal defect, there are two things. One, patient can have ostium premium or patient can have ostium secundum. This we have to understand this thing. Now, what are the clinical features of the ASD? Let's quickly revise the clinical features of the ASD. So the clinical feature of the ASD, first it includes a fixed splitting of the heart sound. So there is a splitting of heart sound, right? Particularly there is a loud P2. I'm just revising quickly the characteristic features of the ASDs. So where there is a fixed splitting of heart sound, there is a loud P2, right? And there can be a pulmonary systolic flow murmur, pulmonary systolic flow murmur, right? And what are the complications of this ASD, guys? If we talk about the complications of this include first of all pulmonary hypertension, right? Patient can land up into cardiac failure. Patient can land up into cardiac failure, right? These are the two complications, and sometimes you can see that there is an infective endocarditis also. So these are the complications. So infective endocarditis, right, cardiac failure, and pulmonary hypertension, these are some of the complications of the ASD. You have to focus that there is a fixed splitting of the heart sound, right? Loud P2. Now, loud P2 means there is, pulmonic valve or the pressures are increasing. That's why there is a complication of pulmonary hypertension. So, this is a quick review of the ASD. Now, let's understand why I have guys. Can you please tell me what is the right answer? You are saying that it can be PDA or VSD. So, I have made it very clear that it is going to be ASD. Now, my question to all of you is this: if we are discussing about ASD, right? What ASD means, what Ostium Primum or Secundum? Among these two, we have to choose one. Then, what is the answer you will choose for? Hanji, can you please tell me what is the answer you are going to choose for? जी बताइए कौन सा आंसर होगा? So let's quickly see what we have in ASD, right? Let's discuss about some of the congenital heart diseases. Let's discuss about some of the congenital heart diseases, guys. Let's make a table. Anatomical defect, so let's quickly revise, guys. I am going to write down about some of the characteristic features. The first very characteristic feature we are going to discuss is about the ostium primum, ostium primum, right? So ostium primum, here we will discuss about the anatomy, anatomical defect, right? So can you please tell me where is the defect in the ostium primer? So okay, so ostium primum, the defect is going to be in the defected side is defect is in the lower part of the atrial septum. Atrial septum, first of all. Second, my dear friend, what are the ECG changes we are going to find? So in ECG changes, we are going to see that the patient is going to have right bundle branch block. Patient is going to have left axis deviation, right? Or patient can have a first degree heart block, first degree heart block. Patient can have a first degree heart block, right? It is associated with mitral regurgitation. One, it is associated with Down syndrome, right? It can be associated with Klinefelters. Now, guys, please pay your focus that when we were talking about this question, let me take back you to the question. The patient was having what beta? The patient was having right axis deviation. You see over here, the patient was having right axis deviation. So guys, if we were talking about the ostium primum, then the patient is going to have left axis deviation. This is the characteristic feature which is going to give you a segregation between the ostium secundum and the primum. So by this left axis deviation, we are out with this ostium primum. So let's discuss about the second part, that is ostium secundum. Ostium secundum. So where the defect, as I told you earlier, here in the ostium primer, the defect is at the lower part of the atrial septum, or we can say it is basically just above the AV valve. One of the same thing, just above the AV valve. But whereas when we are going to talk about the ostium secundum, what is going to happen? The defect is of fossa ovalar. Defect, it's a defect of fossa ovale. Mark it, very important. Patient can have a partial right bundle branch block or a complete RBB, characteristic feature, with right axis deviation. So right axis deviation with a prolonged PR, with a prolonged PR interval, right? So a prolonged PR interval, right axis deviation, right, or patient can have a RBB. All these are the characteristic feature of ostium secundum. That what was the in the MCQ. So it is associated with, guys, first of all, it is associated with mitral valve prolapse. It is generally seen in association with mitral valve prolapse. So guys, now I think we have got the answer, right? That all these characteristic feature that the patient was having, mitral valve prolapse, maybe, and the complication of this thing, ostium secundum, I'm writing over here, complication is atrial fibrillation. So if the complication is atrial fibrillation, understand the concept over here. And in atrial fibrillation, most likely the patient was in AF, and that was a short-lived AF. Patient had right axis deviation and RBB and a prolonged interval. That's why the answer is going to be the ostium secundum, right? So the answer is going to be, guys, ostium secundum. One thing. Okay. Now another characteristic feature we would like to focus what is seen in what you call it as patent ductus arteriosus. Let's quickly revise about patent ductus arteriosus. So what happens in PDA? Where is the problem? Or Hanji, where is the problem, or what are the characteristic feature in the PDA? So here I am just going to write about the quick review of the PDA, what you can find in the MCQ, that you are going to find a continuous machinery murmur. Continuous machinery murmur, right? Patient can have a collapsing pulse. Patient can have a collapsing pulse, right? So these are the two characteristic feature: continuous murmur, patient can have a collapsing pulse, or you can find a left to right shunt, left to right shunt, right? So this is the characteristic feature of a PDA. Yes, Rohit Pandey, your answer is right, that we can see a continuous machinery murmur in PDA. So guys, these are some of the clue and the interesting fact. If you find all this, please try to correlate this question, and then we can proceed accordingly to the question. Okay जी. Ventral septal defect, okay. VSD बेटा, VSD में हम लोग क्लिनिकल फीचर्स क्या क्या देखते हैं? Quickly, let's quickly revise about the clinical features of the VSD. हाँ जी, बताइए. Where do we see the thrill? I am just writing dash thrill. Which thrill we see, and where is the area where we see this thrill? We see this thrill in the parasternal area. In the parasternal area, right? Then yes, murmur, Rohit, you said very well that we see a pansystolic murmur. Pansystolic murmur we see. But my question is this, Rohit, that I agree with your point, beta, that you see a pansystolic murmur. right? Okay. And but where is the loudest where you find this pansystolic murmur? So it is loudest at lower left sternal border or edge, right? There will be a single S2 you can find, and you can find left to right shunt. Basically, there is a left to right shunt. So these are some of the characteristic feature of the VSD. You have to keep it in mind. Generally, guys, they ask this thing that this is a pansystolic murmur. Where do you find loudest, or where do you find a thrill? The thrill is at the parasternal area, right? So these are the quick review about the VSD. I hope you have understand the concept over here. So let's move to the question number 2, and your time starts now. Please read it and then tell me. 10 seconds left, guys. Okay, so let's read the question. What is the most appropriate treatment, and what are the options we do have? First is valve replacement, aortic valvuloplasty, routine follow-up, no further treatment is required. And majority of you have given me a right answer that a routine follow-up. So what is the question? A 50-year-old male non-case of aortic stenosis undergoes a regular follow-up for echocardiography. Echo shows 32 millimeter of mercury pressure gradient across the aortic valve. Now, I would like to know Mithu, Nihar, and Shobhi, Rohit, everyone you have given me answer C, routine follow-up. Why you have given me the routine follow-up? Why you are not going for a valve replacement? Can you please tell me? Why not aortic valvuloplasty? Hanji, it will be interesting to know the fact. Why you have chosen answer number C? See guys, what happens over here that this patient is having a aortic stenosis. Now let's discuss about, means in the question they are asking about the indications of the aortic, what you call it as aortic valve replacement. So let's discuss about the aortic valve indications of aortic valve replacement. Indications of aortic valve replacement. What are the indications, beta? The first very indication is this. That the patient should be a symptomatic patient. Means patient should have an symptomatic aortic stenosis. The patient should be a symptomatic, right? Another indication is this, that the patient should have severe aortic stenosis. Severe aortic stenosis with, very important, left ventricular ejection fraction. Hanji, kitna? How much is the left ventricular ejection fraction? Less than 50%. Severe aortic stenosis with left ejection fraction less than 50%. And this, guys, understand the concept over here, that this ejection fraction 50% or lesser than the 50% should not be because of any other cause. I am writing over here, not of any other cause, not because of any other cause. This is the important thing. So if it is there and ejection fraction is less than, and you are finding that the patient is having hypotension, patient is having weak pulses, patient is getting dyspneic, right? So you obviously going to mark this thing. right? And third indication is this, that the patient is having severe aortic stenosis. Third indication is severe aortic stenosis, right? And the patient should undergo other cardiac, patient undergoing other cardiac surgery. Other cardiac surgery, right? So guys, yeah, undergoing any other cardiac procedure. Rohit, I agree with your point. Okay. So guys, now understand the concept over here. Understand another characteristic feature that I am going to discuss over here is कहाँ गया हमारा? His echo showed how much, कितना है gradient यहाँ पे बेटा? This is the very important line they have written over here. Echo is showing how much beta? 32 millimeter of mercury pressure gradient. But indication includes, if the clear guidelines is, if the pressure is more than 40 millimeter of mercury, only then the indication is going to be there to replace the valve, right? So what we are going to do, we are just going to follow up for a routine surgical, not routine follow up with an echocardiography, or we will follow the routine cardiac consultations. So do understand this concept, that a pressure gradient of more than 40 millimeter, actually the mean pressure gradient across the valve should be more than 40 millimeter of mercury, and that is an indication for the replacement of aortic valve. If it is lesser and patient is asymptomatic, or patient is not going for any other cardiac surgeries and his ejection fraction is more than 50%, guys, nothing to worry, you just have to follow up this patient on a regular basis, right? Okay ji, chalo, let's see the question number 3. Time starts now. Time's up, guys. Let's read the question. What is the most appropriate next step in the management? Right, and the options we do have is IV labetalol, IV verapamil and surgery, oral metoprolol. Let's read the question. A 70-year patient, known case of hypertension and COPD on regular pressurized metered-dose inhalers, present to emergency with central tearing chest pain and was diagnosed as aortic dissection involving the ascending aorta. His heart rate is 130 per minute and blood pressure is 166 and 88. What is the most appropriate next step in the management? So this question is clearly, yes, in the question it is defined that this patient is having aortic dissection. So let's discuss about the aortic dissection. Okay, what I am getting the answer A. A. Okay. Okay, guys. A is, I understand that why you are giving the A. You must be just looking at the blood pressure, or for hypertensive crisis over here. You see, I agree with your point that most of you must be thinking that, sir, इसका तो blood pressure भी higher side पे, heart rate भी है, that's why we are going to give labetalol. Okay, your thinking is like this, but let me explain you. Labetalol is not going to be the answer. Why it is not going to be the answer? You see, this patient is having aortic dissection. First of all, this patient is having what, beta? Aortic dissection, and this aortic dissection is of two types or two categories. First of all, it can be categorized into two parts. First, it is type A, right? this type A basically it affects the ascending aorta. It affects the it is going to affect the beta what ascending aorta, and the definitive treatment for this the aortic dissection which is going to affect the ascending aorta is going to be the surgical repair. Kya hai beta? Is going to be the surgical repair. Now why surgical, or what is the mainstay of the treatment? The mainstay of the treatment is, yes, the mainstay of the treatment is to control blood pressure by intravenous agents. Why intravenous agents? First of all, right? And why we are going to give the intravenous agents? Quickly, to prevent cardiac tamponade, and aortic rupture. First of all, we have to understand this thing, that we are going to do a intravenous agents needs to be given. Why? Because they are going to lower down the blood pressure, and obviously they are going to prevent a cardiac tamponade, and they are going to prevent for the aortic, what you call it as, rupture. Now I have told you that it is going to affect the ascending aorta. So let's see what we had in the question. Here in the question it is ascending aorta, right? Understand the concept. Your answer is going not to be the A. Yes, Nishan, the answer is going to be yes. Answer is going to be C. Why answer is going to be C? Understand over here that here what is written, this patient is on CO, is a non-case of COPD, and he is taking a regular pressurized meter dose inhaler. Now this patient who are having a respiratory disease, they fall under category B or type B aortic dissection, right? It does not involve the ascending aorta. It doesn't involve ascending aorta, right? But since, my dear friend, understand the concept, this patient is having COPD. If you are going to give labetalol in this patient, what is going to happen? It may precipitate the blood. It may precipitate the bronchospasm. So what we are left with? We are left with only one option, that this patient is going to have IV verapamil and surgery. IV verapamil and surgery. Why I am telling you? Because I told you the definitive treatment for a aorta dissection involving the ascending aorta is surgical repair. So surgery is the must thing. Now we have to choose only antihypertensive. Since this patient is having COPD, that's why we are not going to give labetalol, right, or metoprolol is not going to be recommended. Antihypertensives over here. That's why we are left with only one thing, that is calcium channel blockers and verapamil, and definitive treatment is going to be the surgery. Yes, Nishan, bronchospasm you said, right? Okay, ji. Okay, I hope I have made this question clear. So these are tiny little mistakes, quick mistakes. We generally get excited when we see, oh, this one ये question का तो answer है ना. But when we read the question carefully, we can actually find out the depth of the question, or some hidden agenda of the examiner, what they are asking from you. Okay, चलो जी अगले question पे चलते हैं हम लोग. Your time starts now. Okay, time's up. What is the likely cause? And the causes include tuberculosis, transformation into lymphoma, leukocytosis, infection, mononucleosis. Let's read the question. A 60-year-old male chain smoker, known case of CLL, very important, known case of CLL, which is diagnosed 2 years back, for which he didn't took any treatment. Now presented to emergency with complaints of generalized weakness, weight loss, fever from last 15 to 20 days. Very important. From 15 to 20 days. This history is very important. On examination, he is febrile and has a palpable cervical axillary lymphadenopathy and splenomegaly. Okay. So this is the important, means this patient is having lymph nodes present, spleen is palpable. His pulse is 116 and blood pressure is normal 126/66. Okay. So guys, is it okay to say that this fever can cause this type of tachycardia? Is it okay to say this thing? Yes, it is okay to say this, but we can correlate with this question also. Lab report, the patient is having anemia, WBC counts are going to be normal, platelet count are on a lower side. Normal platelet count is 1.5 to 4.5. LDH is on a very higher side. CRP is on a higher side. Urine routine is normal. Chest X-ray is unremarkable. So what is the likely cause? Hanji guys. So let's read the causes first of all. Is it going to be tuberculosis, guys? No. Answer it is no. It's not tuberculosis. Why? See, understand the concept. I do agree with your point that in tuberculosis we can find adenopathy can be there and sometimes splenomegaly is there, but in tuberculosis isolated splenomegaly is rarely seen, first of all. Secondly, my dear friend, here the x-rays are saying unremarkable. Had it been tuberculosis, maybe there was some cavity formation, maybe there was calcifications would have seen, means there must have some history of abnormal chest x-rays, one thing. And secondly, there must have some cough with sputum, evening rise of temperature. So in the question nothing has been mentioned, although the patients with immunocompromised patient like CLL, they are prone to develop the opportunistic infections, or some patients see the cause of tuberculosis, even the low immunity is there. But still the examination, from examination point of view, or from the lab investigation, they are giving the x-rays, they are giving normal. So I am taking out this tuberculosis, one thing. Okay, I will discuss this later. Let's discuss about leukocytosis. Is the answer going to be, yeah, WBC is also normal. Yeah, you are right, WBC is also normal, Dr. Metroid. WBCs are normal, right? Okay. Is the answer going to be leukocytosis or transformation into lymphoma or infectious mononucleosis? See, infectious mononucleosis is a syndrome of fever. It's basically a syndrome of fever, pharyngitis, lethargy, right? Patient can come with lethargy. Patient can with lymphadenopathy also. Lymphadenopathy, right? All this can come. Particularly, guys, I am writing over here that in infectious mononucleosis, posterior cervical lymph nodes are the common one. CL means cervical lymph nodes are going to be enlarged, and it is most commonly caused by which virus? Epstein's Barr virus. Epstein's Barr virus, or herpes simplex virus. Herpes simplex virus, right? Toxoplasmosis, or even in HIV patients. So guys, they are saying us that the patient is having cervical axillary lymph nodes. So this is also out of our concern. Now we are left with only two things: either the answer is going to be leukocytosis, or it is going to be transformation into lymphoma. So can you please help me in finding out the right answer between these two, transformation into lymphoma or leukocytosis? What do you say? Okay, majority of you is saying, sir, it is going to be the transformation into lymphoma. Totally, I agree that this is a case of CLL, and in the case of CLL, guys, what happens that CLL transforms into a lymphoproliferative disorders. So it transforms into a lymphoproliferative disorder. Now, what kind of lymphoproliferative disorder it is going to be? Yeah, it is going to be in it can be a Hodgkin's, It can transform into Hodgkin's, or it can transform into non-Hodgkin's lymphoma, first of all, right? Or it can go into promyelocytic leukemias, promyelocytic leukemia, or even into a multiple myeloma, MM, right? Now this will basically, it is going to, the patient is going to have a characteristic feature, first of all, that the patient is going to have progressive lymphadenopathy. The patient is going to have progressive lymphadenopathy, one thing, right? Patient is going to have splenomegaly. Patient is going to have splenomegaly, right? And patient can have symptoms like night sweats. Patient can have symptoms like night sweats, fever, or patient can have weight loss. Patient can have night sweats, fever, weight loss, and it is associated with, guys, anemia, like fall in the HV, right? Thrombocytopenia. So I'm just writing low platelets means thrombocytopenia, right? An increase in LDH levels. So guys, this type of transformation into lymphoma, it occurs basically in approximately 10% of the patients, and in general it occurs within 2 to 4 years of the diagnosis, and it has a poor prognosis. So it has a poor prognosis. It has a poor prognosis, right? So my answer is going to be transformation into lymphoma, one thing. Do understand thing. Right now we were left with only last thing, that was what? Leukocytosis. Now understand the concept that in leukocytosis what happens, my dear friends, it can occur in any kind of leukemia. One thing, it can leukocytosis, name itself is suggesting leukocytosis, but understand the language of this, that here if the patient had been into leukocytosis, look at the WBC count. Here the WBC counts are normal, right? But whereas if the patient had leukocytosis, his WBC should have shooted up. So that's why we are left with only one answer. That is what, beta? That was transformation into lymphoma, right? Okay. So Sana, Metroid, very good, guys. Very good. And you, Sana, said also WBCs are normal. Okay. So let's read this question. You are left with 10 seconds. Okay, ji, let's read the question now. What is the likely cause? Iron deficiency anemia, beta thalassemia minor, chronic disease, congenital sideroblastic anemia. So, guys, what do we have to read the question? A 27-year-old lady visits you with complaints of generalized weakness, lethargy from last few days. She don't give any history of menorrhagia or any other symptom. She don't have any significant previous medical history and is not on any medicine. Clinical examination is normal. Lab report shows HB. Patient is having anemia. First of all, patient is having anemia. WBC count is 8400. MCB is on a lower side, platelet count is on a normal side, serum iron is normal, iron binding capacity is also normal, ferritin is 78, okay, normal, transferrin saturation is 30%, biofilm, blood film, hypochromic microcytic anemia, occasional target cells. This is the clue. हाँ जी. So guys, I really appreciate the answer of Gayatri. You have given me a right answer. So it is going to be the beta thalassemia minor. See, why it is going to be a beta thalassemia minor? Understand the concept over here. See, uh, what happens, my dear friend? There are normal iron studies. First of all, let's see in the question that what is happening over here. See, in the question, there are normal iron studies, right? That means this patient is going to have an underlying hemoglobinopathies, right? And this hemoglobinopathy is most likely because of microcytic anemia. It is because of what, beta? Microcytic anemia. Here it is even written microcytic anemia, right? Now, if I talk about, particularly about beta thalassemia minor, right? If I talk about beta thalassemia minor, now usually the patient is having a mild category of anemia. First of all, mild category of anemia is going to be there, right? And first we start suspecting when we find that patient is having microcytic, and that seems to be, a mild type of anemia. One thing, and why I am choosing this answer over here, that among all these things I am focusing upon this thing, that in the blood film you may find that there are target cells over here, but to confirm the diagnosis of beta thalassemia minor, what you have to do, you have to go for hemoglobin electrophoresis. You have to go for electrophoresis, right? And you have to check for HbA2, that is going to be more than 3.5%, right? Now, why you have been saying, Rohit, why you have been saying iron deficiency anemia, right? Now, iron deficiency anemia, note दोस्त यहाँ पे देख सीरम आयरन लेवल्स कितने हैं, 18 है, नॉर्मल रेंज इज 12 to 30. So in iron deficiency anemia, मेरे दोस्त serum iron level are reduced over here, right? And in hemoglobinopathy, they are going to be the normal one, right? People who have given me, okay, you have given me D also. D is not the answer. I am replying you. किसने दिया हुआ है D answer ये? अभी कहाँ था? Nihar Ranjan, you have given me the D answer. Beta is D answer in sideroblastic anemias में, chronic sideroblastic anemias में serum iron level are going to increase, right? So we had a detailed discussion about the type of anemia, so you can check that lecture, we have discussed upon that, right? Okay. Yeah, Gayatri, I agree. All normal seen in thalassemias. So in thalassemias, you may find that there is a normal serum iron. You may find a total iron binding capacity. Ferritin level is normal, right? So all these are things going to be a normal. You can make the diagnosis only on the electrophoresis. So the answer is going to be beta thalassemias. Okay, in chronic diseases, what happens, my dear friend, that this serum iron is going to reduce. TIBC को क्या होगा बेटा? TIBC is also going to reduce. Transferrin saturation is also going to reduce, right? Ferritin level is going to increase, or it's going to be a normal thing. It can be a normal one. So now you can frame out this thing. Actually, you know, the length of the question or the story of the question is bigger. But if you find that the findings are very, you know, what you call it, very easy to answer this question. Can we proceed to the next question now? Time starts now. Time's up, guys. Time's up. So you are going to give me the answer B. Factor 8 concentration. Von Willebrand factor is a carrier for factor 8. Okay, Gayatri B. Gayatri B. Guys, let's read the question. What is the most appropriate prophylaxis for bleeding before her dental procedure? Let's read the options: vitamin K, factor 8, desmopressin, and protamine. A 34-year-old female has been investigated for menorrhagia and diagnosed with the von Willebrand's disease. She had to have a molar extraction in a week time. What is the most appropriate prophylaxis for bleeding before her dental procedure? Put your pens down, guys, and understand the concept over here. बड़ा simple है समझना इसको. It's very simple to understand. The question itself is saying that this lady is going for a dental procedure. Understand the concept. How risky is this dental procedure? How much bleed is going to be there? It is going to take a lot of bleed. Only a minor type of bleed, a regular type of bleed is going to occur. First of all, you have to understand. Is this patient going for a major surgery? Yes or no? No, it is not a major surgery. It is going to be, you know, a routine a day procedure where the chances of bleeding are very less, very, very less. First of all, do understand this thing. Now, why I am going to choose the answer over here? Why I am going to choose the answer? First of all, vitamin K is not the answer. First of all, why vitamin K? See, understand the concept over here that the prothrombin complex, concentrates, and vitamin K are useful in restoring the stores of the vitamin K dependent clotting factors, that particularly, you know, 2, 7, 9, and 10. And they are basically used in most of the cases. They are used basically in most of the cases where bleeding is related with, you know, warfarin or overdose, or, you know, so they are used mainly in cases where the bleeding is because of warfarin, right? One thing, patient is having some, you know, decompensated liver disease, DLD. I am writing decompensated chronic liver diseases, right? Two things you have to understand. I am not choosing this protamine also. See why protamine is, you know, it's basically, you know, the what you call it as antidote for heparin. So we are not going to give heparin to this patient. So protamine is also out, right? First thing. So we are left with only two things: we are left with factor 8 concentrates or desmopressin. Now understand the concept over here, that guys, desmopressin can be given, on regular basis. You can give intranasal, you can give even subcutaneously, right? You can give even subcutaneously. So you can give subcutaneously. So you have, this benefit of giving intranasal, subcutaneous, or even you can give IV, right? Now, if the patient is going to visit this, his or her dentist whatsoever, right? This patient is going to have a very low risk of bleeding. This patient is having very low risk of bleeding, and it is not so expensive, easily given, low risk of bleeding. And if this patient is having low risk of bleeding, you can easily give this intranasal and you can control the bleeding first of all. Now we are left with only factor 8 concentrates. I do agree with your point that this factor 8 concentrates needs to be given, but guys, this factor 8 concentrations are given in only those patients where there is a high risk of bleeding. Kahan pe beta? High risk of bleeding. High risk of bleeding, right? And secondly, we have to give this factor 8 where the desmopressin doesn't shows any effect, or the effect of the desmopressin fails to control the bleeding. There only we are going to give this factor 8. And secondly, some more, in Indian scenario, this factor 8 is an expensive thing to give, so as compared to desmopressin. So looking at the dental procedure low risk, the answer is going to be a desmopressin. Okay, let's proceed to the next question. Hanji, on a biofilm, which among the following doesn't cause Howell-Jolly bodies? Myelofibrosis, CML, multiple myeloma, sickle cell anemia. So guys, before I proceed to the answer, I would like to know what is this Howell-Jolly bodies? Hote kya hai? What is this? Can you please tell me what is this Howell-Jolly body? So Howell-Jolly bodies are basically, these are the nuclear remnants in a erythrocyte. So basically kya hai beta? These are the presence of, it's a name given for the presence of, remnants, nuclear remnants in erythrocytes right? And this type of erythrocytes, they are removed by the spleen, what you call it as, but their presence leads to the malfunctioning or the hypofunctioning of the spleen and causes hyposplenism. Hyposplenism, right? Now question is this, where do we find this kind of hyposplenism, right? What this hyposplenism can further lead to, it can basically be seen in myelofibrosis, It can be seen in myelofibrosis, CML, or sickle cell anemia. Multiple myeloma, it's not going to be, a part of this Fowell-Jolly bodies. Yeah, asplenism, I do agree with this points, Rohit Pandey. So in all these features, we can see a defect, but in multiple myeloma, it's not going to be a cause. Okay, ji. Very easy question. So what you have to think, what are the causes of gynecomastia? What are the drugs causing gynecomastia? Gayatri, you are saying spironolactone as the cause of gynecomastia, or it does not causes gynecomastia? I am not, I'm not getting your answer. What you want to say? Please write the options A, B, C, D. Guys, do remember the very easy causes of gynecomastia. What are the causes of gynecomastia? When I was a student, I just made a mnemonic SAD CM. SAD CM. Right? SAD CM means I'm just telling you about the causes of gynecomastia is SAD CM. So SAD CM means, first of all, as per spironolactone, S is spironolactone, A is alcohol, D is digoxin, right? C is cimetidine, M is what beta? Methyl dopa, or M is metronidazole. Metronidazole. So we have spironolactone, alcohol, digoxin, cimetidine, methyl dopa, and metronidazole. These all are the options. So what we are left with the answer that there is nicorandil is not going to be the drug which is going to cause gynecomastia. So do remember this mnemonic causes of gynecomastia is SAD CM. Mnemonic is SAD CM. Yeah, D is the right answer. Okay, ji. Let's read to the next question. Can we discuss the question? Time's up. What is the most likely cause? Options we have is capecitabine, bleomycin, cisplatin, vincristine. And the question is, a 60-year-old male patient complains of colorectal cancer on chemotherapy. Since last 3 weeks, he visits you with blisters, rash on his palms and soles of feet. What is the likely cause? Now, before you proceed further, can you please tell me what this patient has basically, what problem he is dealing with? इसको हुआ क्या है बेटा? So from the question we have understood that this patient is a known case of cancer and he must be receiving some chemotherapy as in the question, and we know that every chemotherapy has some side effect. So what the question is all about, it's all about the side effect of all these drugs. So you just have to dig the answer from your brain, and I am pretty sure that you are going to give me the right answer. B is not going to be the right answer. B is not going to be the right answer because the most common side effect of bleomycin is what beta? Lung fibrosis. क्या है बेटा? Lung fibrosis. So lung fibrosis कोई shortness of breath, dry cough, this is not there. So B is not the answer. Okay. Yes, Nihar Ranjan, I totally agree with your point that it's basically a hand-foot syndrome. I appreciate your answer, beta, that it's a hand-foot syndrome. क्या है? It's a hand-foot syndrome, right? So those, agar if it is a hand-foot syndrome, can you please tell me which drug is responsible or which drug is associated with a side effect of hand-foot syndrome? This you have to just, get from your previous knowledge. Okay, so people who have given me the right answer, the hand-foot syndrome is a common side effect of capecitabine. So here we write that the side effect is hand-foot syndrome. First of all, bleomycin. I have already told you this patient can develop, lung fibrosis. What is the side effect of cisplatin? The side effect of cisplatin includes, first of all, it can cause interstitial nephritis. It can cause beta what? It can cause interstitial nephritis. One thing, it can cause peripheral neuropathy. It can cause peripheral neuropathy, right? It can cause ototoxicity. It can cause ototoxicity. So interstitial nephritis, peripheral neuropathy, or ototoxicity. Now we are left with vincristine. What is the side effect of the vincristine? Vincristine is responsible to cause beta peripheral neuropathy. Neuropathy. Right. Apart from this, there are 2-3 other important drugs. I'm just going to discuss about some of the common side effects. If they can ask you, they ask you doxorubicin, one of the common drug. Just a quick review. What is the doxorubicin? Hanji, side effect of doxorubicin is cardiomyopathy. And skin rash. This is another common drug which side effect is being asked, right? Methotrexate is another common drug. Methotrexate is another common drug whose side effect has been asked multiple times, right? So can you please tell me what are the side effects of methotrexate? M for methotrexate, M for mucositis. Mucositis. It can cause myelosuppression. It can cause myelosuppression. It can cause liver fibrosis. It can cause bit of what? Liver fibrosis, and it can also cause pneumonitis. Pneumonitis. So these are some of the drugs which are the important drugs, anti-cancer drugs whose side effects needs to be remembered all the time. These anti-cancer side effects should be there upon your tips. Okay. So let's proceed to question number next. Okay, guys, time's up. Your answers, please. So let's read the thing which among the following is the likely cause: metoprolol, ibuprofen, bendraflumethiazide, valproic acid. Let's read the question. A 70-year male visits your clinic with complaints of generalized weakness, lethargy. Lab report shows sodium is 136, potassium is 6.4, creatinine is 2.8. So those पहले सबसे ही तो मेरे को ये बताओ कि इस पेशेंट को हुआ क्या है. बेस्ड अपॉन दिस जनरलाइज वीकनेस है, इसको लिथार्जी है, patient is having what, this one is abnormal and this one is abnormal. So normal potassium range I am telling you is 3.5 to 4.5, right? And serum creatinine should be less than 1.9 is the upper limit, 1.9. But here you see the creatinine level has increased, potassium level has increased. So this patient, Rohit Pandey, I agree this patient is having hyperkalemia. But can you correlate with this, the drugs and the, potassium and the creatinine level, what this patient is having, and with this generalized weakness, lethargy. So this patient has basically landed up into acute kidney injury, right? First of all, this patient is having acute kidney injury. Yes, Nihar, I do agree with your point that this is an acute kidney injury. First of all, now we know this thing that acute kidney injury is associated most commonly with the use of what beta? It is most commonly used with the prolonged use of, NSAIDs, non-steroidal anti-inflammatory drugs, right? Now, among the options given, my dear friend, among the options given, I would like to go for ibuprofen. Why ibuprofen? Because among all the drugs, if I talk about bendraflumethiazide, right, it causes what beta? It causes low potassium. First of all, it causes hypokalemia. Do remember this thing. It is associated with hypokalemia and hyponatremia. Both are associated with this thing. But here in the question, we do have what beta? The potassium level has increased. So bendraflumethiazine is out of this thing. Okay. Now, guys, yeah, ibuprofen is the right answer. Ibuprofen is going to be the right answer. Guys, this is important. So quickly revise mnemonic of the drugs which are causing hypokalemia. Oh, sorry, which are causing hyperkalemia. Drugs which causes hyperkalemia. Which causes drugs? Can you please tell me some of the drugs which causes hyperkalemia? So the easy mnemonic is what beta? The very easy mnemonic is CADK bank. CADK bank. Right. Now what does this C stands for? This is the mnemonic CADK bank. C is first of all calcineurin inhibitors, like what do you call it as calcineurin calcineurin inhibitors. Calcineurin inhibitors. First of all, yes, tacrolimus, right? Like tacrolimus, right? Cyclosporin. These are the two common drugs, right? Then A is for ACE inhibitors. A is for ACE inhibitors. D is for digoxin. Right? Then K is for beta potassium sparing diuretics. K is for potassium sparing diuretics. Diuretics like spironolactone. Like spironolactone. Right? Then we have beta blockers, right? Here is the beta blockers. Beta blockers. Why I haven't chosen, there was metoprolol. They are less likely to go for, renal failure. Acute kidney injury nahi hoti hai inse. That's why I haven't chosen this one. A is for, angiotensin 2 receptor blockers, ARB blockers, particularly that of type 2. N is for NSAIDs, and K is for potassium supplements. Potassium supplements. So these are some of the common causes of hyperkalemia, guys. This is very important, and generally this is a frequent and repeated MCQ. It can come you in a story base. It can come in a one-liner. So you should be, having this, causes of hyperkalemia upon your fingertips. Do revise this thing very well. Okay. Can we proceed to the next question? Hanji, guys, can we discuss? So eruptive xanthomas are associated with which lipid condition? I think this is very easy question. So the answer is going to be the hypertriglyceridemia. This is the characteristic feature of, xanthomas. Hypertriglyceridemia is going to be the characteristic feature of this thing. See, this familiar hypercholesterolemia, it can present with the, xanthelasmas, or it can present with tendon xanthomas. It can present with tendon xanthomas. And if this patient is having a familiar hypercholesterolemia, why I'm telling you this thing? Because you may encounter a question, but there is a characteristic feature of this familiar hypercholesterolemia that this patient generally they have abdominal pain and pancreatitis. They have generally abdominal pain and pancreatitis, right? So this was an easy question. So we can proceed with the further question. Time's up, guys. Answers, please. So let's read the question. Presuming that she is having malignancy, what is the most useful test for a regular follow-up? And the options we have is carbohydrate antigen 125, CA 19 9, alpha fetoprotein, and HCG. Okay, G. Human chorionic gonadotropin. Okay, so let's read the question. A 55-year-old female visits her family physician with complaints of generalized weakness, abdominal pain, and swelling. She says that she finds that her routine outfits are loosened significantly from the last 2 months. So there is a significant history of weight loss. One thing is this thing. On examination, there is a palpable mass in the left iliac fossa that was felt to arise from pelvis. Okay. So guys, there are two, three things hidden in this question. Presuming that she is having malignancy, another important line. Malignancies. One thing. One thing. What is the most likely this thing? Now, what are the hidden clues over here? First of all, this abdominal pain and swelling. This is the first clue, and this whole line itself that her fine routine outfits are losing significantly from the last 2 months. Now, guys, to understand this concept, this is a clue for you. If in the MCQ it is written significant weight loss means approximately 10 or more than 10% of the actual weight loss within 2 months, we call it as a significant weight loss. Sometimes it is quite possible that the patient haven't measured his or her weight from a quite few time. But it is quite a often question you ask from the patient that, sir, have you lost weight? He says, I haven't checked. Then what is the other way to ask? Is your clothes been loosened from the last 2 months? If they say yes, my t-shirt, my pants, or my whatever the outfits they wear, they are loosened and they are significantly loosened. It means there is a significant weight loss. This is another indirect questionnaire from the patient. Leading to the question on examination, there is a palpable mass in the left iliac fossa to arise from this thing, presuming that she is having malignancy. Now, my question to you is this, and some more they are asking useful test for regular follow-up. First of all, before we proceed this question, guys, please stimulate your nerves and tell me in the chat box that what kind of malignancy this patient is likely to have. हाँ जी, फीमेल है, 55 ईयर्स की है, कौन सी मेलिग्नेंसी हो सकती है? व्हाट टाइप ऑफ मेलिग्नेंसी इज गोइंग टू बी देयर? Anyone? So guys, this lady is likely to have a ovarian tumor. Ovarian tumor, likely to have a ovarian tumor, right? And they are asking us if this lady is yeah, Nihar, I agree with your point, and Ashi, I totally agree with your point, and I appreciate your answer. It's going to be an ovarian tumor, and we know this thing that if this patient is having ovarian tumor, and the test or the diagnosis or the screening or the follow up, what we use is CA 125. CA 125. This CA 99 is basically used for pancreatic cancer. Pancreatic cancer, right? Alpha fetoprotein is basically used for hepatocellular carcinoma and germ cell tumor, right? And HCG is basically used for, yes, sarcomas. Oh, sorry, not sarcomas, seminomas. Seminoma, or we also use it for germ cell tumor. For germ cell tumor. So this basically is used for what, beta? Ovarian cancer. Ovarian cancer. Okay, I think we are done with this question. So let's lead to the next question. A very simple question, guys. Very simple question. Which among the following causes a right shift in the oxygen dissociation curve? So, Bohr effect, they are talking about the left shift of the right shift. So, let's quickly discuss about the causes of right shift. Causes of right shift. So, first of all, causes of right shift is raised temperature. One thing to understand, right? Raised temperature, increased PCO2, acidosis, right? So increased PCO2, if increased PCO2, this is going to be the answer. Acidosis, right? Then we do have exercise, right? Exercise. Then increased 2,3 DPG, 2,3 DPG. These are some of the causes of oxygen dissociation curve shifting towards the right side. Another cause, left shift. Where do we see this thing, guys? First of all, reduced temperature, decreased PCO2, alkalosis, decrease 2,3 DPG, right? Increased carbon monoxide concentration, right? These are some of the causes. So this simple answer was there. So the answer was raised temperature for this question. Let's quickly proceed to the next question. Sanjay, guys, time's up. Let's read the question. What is the most likely cause? Hyperventilation, lactic acidosis, vomiting, high flow oxygen. Okay, a 70-year-old man who is a chronic smoker is brought by ambulance into emergency. He was complaining of progressive shortness of breath. In ER, you order an ABG. So you just have to interpret the ABG. That is it, right? Okay, so you just have to interpret the ABG. pH कहाँ पे है बेटा? लोअर साइड पे. What is the normal range of pH? Normal range is 7.35 to 7.45. So it is on a lower side. One thing. PCO2 is on a higher side. Normal range is 35 to 45. So this patient is having a higher PCO2, right? So it means the cause is going to be some respiratory. PO2 is going to be 135. Normal is up to 85 or more than 85, up to 100, you can say it, right? 85 to 100 is going to be the normal. So it has increased over here. Bicarbonate 24 plus minus 2 means it range between 22 to 26. Now can you please tell me how it is going to happen? Now make it a thumb rule, guys, that this patient is a chronic smoker means likely the patient is having COPD or acute exacerbation of COPD, because this patient is having progressive shortness of breath. So one thing is very clear, right? Now point to be noted over here, that you are bringing this patient in the ambulance to the ER. So in a ambulance, the staff nurse or the technician or maybe a medical officer, a resident doctor, they must have put, the oxygen, very common thing, right? I think they have done a right job. That's why when they are putting, the oxygen over here, you can see that the oxygen level has increased significantly. The PO2 level has increased significantly. Point to be remembered over here, that if this has increased significantly, what is happening? Why it is not going to be, it's not going to be a hyperventilation. First of all, let me define one by one. It is not going to be hyperventilation. Had it been hyperventilation, what would have happened? That the CO2 level would have reduced. CO2 level would have reduced. So hyperventilation is out, first of all, because the CO2 level is increasing. Second, my dear friend, that in a case, do always remember this thing. I'm just giving you a simple way. I have a detailed lecture on ABG. I will discuss over there. Right. Now understand the concept. We are giving oxygen to a person. Right. If we are giving oxygen to a person, what happens? If you give more oxygen, carbon dioxide is also going to increase significantly. It is also going to increase significantly, one thing. In cases of respiratory acidosis, pure respiratory, if I talk about, then if the pH falls, what happens? If the pH falls in a case of CAPD, then the carbon dioxide is going to, CO2 is going to increase, and bicarbonate is also going to increase. HCO is also going to increase in the case of respiratory acidosis, right? In acute cases, in acute respiratory acidosis, what happens, my dear friend? That ratio I am talking about, if the carbon dioxide increases by 10, bicarbonate increases by 2, and in chronic cases, the bicarbonate, if the carbon dioxide increases by 10, bicarbonate increases by 4. This is in chronic cases. But here you find that the bicarbonate level is going to be a normal one. That's why it is high likely chances that in the ambulance they have given a high flow of oxygen. High flow of oxygen. So people who have given the answer as D, like Ashi, you have given the answer D, right? So I appreciate your answer. बेटा लैक्टिक एसिडोसिस नहीं है आंसर, क्योंकि बाइकार्बोनेट देखो ना यहाँ पे, लैक्टिक एसिडोसिस नॉट गोइंग टू बी द आंसर. एसिडोसिस होता तो बाइकार्बोनेट भी फॉल होता ना यहाँ पे, अगर ये मेटाबॉलिक होता है ये, राइट. सो आंसर इज गोइंग टू बी डी. वॉमिटिंग भी नहीं है, नहीं. वॉमिटिंग में बेटा परसिस्टेंट मेटाबॉलिक अल्कालोसिस की तरफ जाएगा ये. And there is, because of there is a loss of gastric fluid, there is a, loss of secondary to loss of hydrogen ions in the gastric fluid जो loss होता है, उसके कारण hypokalemia होना start होता है, bicarbonate will fall down. चलो next question. हाँ जी, very interesting question. Time's up, guys. Which among the following is the likely cause? Metformin, aspirin, benzoflumethiazide, acetazolamide. A 55-year-old, it is old, known case of hypertension, diabetes, and a previous history of CAD presents to you with the complaints of weakness, muscle cramps, and frequent urination. Which among the following is the likely cause? See guys, answer is very simple over here. You just have to tell me कि इस patient को हुआ क्या है? What is this patient dealing with? What this patient is dealing with? What is this patient dealing with, guys? See, guys, no, diabetes mellitus, I know it is written in the question, but based upon these options, metformin, aspirin, and correlating with their history, patient diabetic hai, patient is having a previous history of CAD. That's what I am asking. नहीं, lactic acidosis नहीं है निहार. ठीक है, I do agree because you have read metformin. That's might quite possible that you are getting confused that this patient is having lactic acidosis. Read this line that this patient is having, CAD. This patient is having CAD. So most likely, based upon this question, this patient is having weakness, muscles, cramps, and frequent urination. And among this patient, most likely the patient had a CHF, might quite possible CHF patient had, or maybe because of CAD, this patient was on, diuretics. So first of all, now weakness, muscle cramps, and frequent urination. These all are the features of hypokalemia. These all are the features of hypokalemia. Now I have given you a clue. This patient is dealing with hypokalemia. Now yes, Ashi, you have given me a right answer because of diuretic hypokalemia. I appreciate your answer and I appreciate your thought process. This is the patient is having hypokalemia. Now guys, I have told you this patient is hypokalemia, and we know the cause of hypokalemia is, among all these options, is benzoflumethiazide, right? So this is the answer. Acetazolamide is basically associated with metabolic acidosis, right, with a normal anion gap. Metformin, again metabolic acidosis, right? And this aspirin is also associated with metabolic acidosis with a raised anion gap, basically. So aspirin, increased anion gap with metabolic acidosis. Acetazolamide, metabolic acidosis with normal anion gap. So guys, this was all for today's session. I hope you have revised a lot of things, and you have tried to come with all of critical thinking to solve the MCQs. Keep on solving the MCQs. Keep on reading the theory. Only then, once you read the theory for at least 4-5 times, then try to solve out the questions. And trust me, guys, this is the only way when you're the way to achieve your success. So, guys, thank you very much. I really appreciate your presence and I really appreciate your participation in the chat boxes. Wish you a good luck. We'll see you in the next class. Thank you and good night to all of you.